This is for range of motion of the ankle. I'm going to use the goniometer, and it's going to be placed over the fulcrum of the lateral malleolus. The stationary arm will be in line with the fibular head. The moving arm will be in line parallel to the fifth metatarsal. The normal ranges for dorsiflexion is 20. Can you please point your foot up to the ceiling? And yours is 22, which is above the range of motion. For plantar flexion, can you put your foot down to the floor, please? The normal range of motion is 50, and yours is at 58. For inversion, eversion of the ankle, using the goniometer, the fulcrum will be placed between the medial and lateral malleoli. The stationary arm will be in line with the tibial crest, and the moving arm will be in line with the second metatarsal. For inversion, can you move your foot inward, please? Thank you. The normal range of motion is 35, and yours is below range of motion at 31 degrees. For eversion, can you move your foot outward, please? Thank you. The normal range of motion is 15 degrees, and you're below range of motion at 9 degrees. For the first manual muscle test, we're going to be looking at the soleus. I'm going to have the patient put her knee at a 90-degree angle. I'm going to stabilize the lower leg at the heel and the calcaneus. The patient is going to have her foot in plantar flexion, and she's going to try to resist. Manual muscle test will be for the tibialis posterior. The patient is starting in the neutral position, and she's going to dorsiflex and invert her ankle, and I'm going to evert it, and she's going to resist. Go. This manual muscle test is for the fibularis longus and brevis. Normally, the patient would dorsiflex and evert, but we're going to resist, so we're going to have her plantar flex and invert and resist. This is the manual muscle test for the tibialis anterior. Normally, the patient would dorsiflex and invert, but instead she's going to plantar flex and evert so that I can grade her resistance. Ready? Good. Manual muscle test is for the extensor hallucis, longus, and brevis. I'm going to stabilize her foot at the metatarsals, and I'm going to push her big toe into flexion. This manual muscle test is for the flexor digitorum, longus, and brevis. I'm going to stabilize her foot at the heel, and I'm going to flex all the toes except for the big toe. Manual muscle test is for the flexor digitorum. I'm going to stabilize at the heel, and this is for flexing the digits. So this is the manual muscle test for the flexor hallucis longus. I'm going to start by stabilizing the patient's foot at the heel, and I'm going to extend her toe, and she's going to resist. This manual muscle test is for the abductor hallucis. I'm going to start by stabilizing the patient's foot at the heel, and I'm going to abduct her big toe.
A common ankle injury is a tear or rupture in the Achilles tendon, otherwise known as the calcaneal tendon. The calcaneal tendon is the insertion point for the gastrocnemius on the calcaneus bone in your ankle. There are several risk factors involved with the tearage of the Achilles tendon. The peak age for the Achilles tendon rupture is from 30 to 40. Achilles tendon rupture is up to 5 times more likely to occur in men than women, and those who play recreational sports are put more at a risk as a stressor of the tendon. Some symptoms of a Achilles tendon tear is pain above your heel, especially where you stretch your ankle or stand on your toes. It can get mild, but it can worsen over time. If the tendon completely ruptures, the pain is instant and severe, and it may feel tender, swollen, and stiff. If the Achilles tendon tears, you may hear a snapping or popping noise when it happens, along with bruising and swelling. Some causes of an Achilles tendon tear or rupture is when someone does increased intensity of sports participation, excessive jumping, falling from a height, stepping into a hole, or wearing high heels or excessive uphill running. In order to diagnose an Achilles tendon tear, the doctor will do a physical examination. They may ask you to go walk or run to look for problems that may have led to your injury. There is also another test called the calf squeeze test. You'll kneel on a chair or bench or lie on your stomach on the exam table. Then she will gently squeeze the calf muscle on your healthy leg. This will pull on the tendon and make your foot move. This will be the baseline for the other leg that may have the Achilles tendon rupture. If the Achilles tendon is torn, your foot will not be able to move because the calf muscle won't be connected to the foot. There are two options to treat an Achilles tendon tear or rupture. There is non-surgical treatment and surgery. Non-surgical treatment involves resting the tendon by using crutches, applying the rest, ice, compression, and elevation formula to the tendon, or taking over-the-counter pain relievers. By keeping the ankle from moving for the first few weeks, the tendon has time to be able to walk comfortably in a cast or boot heel wedges. The surgery typically involves making an incision in the back of the lower leg and stitching the torn tendon together. Depending on the condition of the torn tissue, the repair might be reinforced with other tendons. Complications that can include are infection and nerve damage. Minimally invasive procedures reduce infection rates over those of open procedures.